Durvalumab after chemoradiotherapy in stage 3 non-small cell lung cancer. Definition: most patients with locally advanced unresectable non-small cell lung cancer have disease progression despite definite chemoradiotherapy. This phase 3 study compared the anti-programmed death ligand 1 antibody, Durvalumab, as consolidation therapy with placebo in patients with stage 3 who did not have disease progression after 2 or more cycles of platinum based on chemoradiotherapy.
Lung cancer can start in the windpipe, the main airway, or the lungs. It develops when there is uncontrolled growth of abnormal cells inside one or both lungs. These cells grow to form tumours. More than 8 out of 10 cases of lung cancer in the UK are caused by smoking. If you're a smoker, quitting is the best thing you can do for your health. Passive smoking also increases the risk. Lung cancer is more common in older people and in people with previous chest problems or lung diseases such as emphysema. Other risk factors include exposure to radon gas, air pollution, and chemicals in the workplace. A cancer that starts in the lung is called a primary lung cancer, while a cancer that starts in another part of the body and spreads to the lungs is called a secondary lung cancer. The stage of a cancer refers to its size and how far it has spread. Doctors look at the size of the tumour, whether it is in the lymph nodes, and whether it has spread to another part of the body. A small cancer that is just in the lung is likely to be an early stage cancer. One that has spread into the surrounding tissue or to another part of the body is an advanced cancer. You can find out more information about lung cancer by visiting the Cancer Research UK website.
Application in medicine. We randomly assign patients in a 2:1 ratio to receive Durvalumab at a dose of 10 mg per kilogram of body weight intravenously, or placebo every 2 weeks for up to 12 months. The study drug was administered 1 to 42 days after the patients had received chemoradiotherapy. The co-primary endpoints were progression-free survival and overall survival. Secondary endpoints included 12-month and 18-month progression-free survival rates, the objective response rate, the duration of response, and the time to death or distant metastasis, and safety.
Treatment and management of small cell lung cancer. Most patients with small cell lung cancer receive chemotherapy, or chemo for short, and radiation therapy. Other forms of care include supportive care to ease pain and discomfort, prevent and treat side effects, help you deal with stress and anxiety, and help you stop smoking. Palliative care is also important to ease symptoms and improve quality of life. For patients with limited-stage small cell lung cancer, surgery is a possible option if the disease is a single small tumor, and there are no signs of cancer in the lymph or elsewhere, and the patient is healthy enough for surgery. However, less than 1 in 20 patients with small cell lung cancer can be treated with surgery. If surgery is possible, and depending on how far the cancer has spread, the surgeon might remove an entire lobe, called a lobectomy, or the whole lung, called a pneumonectomy. The surgeon must also remove nearby lymph nodes to check for cancer. Unfortunately, surgery can't be used for most patients with limited-stage small cell lung cancer because most of the time the tumor is too large, or the tumor is in a place where it can't be safely removed, or the cancer has spread to nearby lymph nodes or other places in the lung. Patients in good health are usually treated with chemo plus radiation to the chest. Less healthy patients get chemo by itself, although sometimes the chemo is followed by radiation to the chest. Another option would be a clinical trial for a new treatment. For extensive-stage small cell lung cancer patients, chemo is used to shrink the cancer and ease symptoms. If the cancer shrinks, radiation to the chest might help control the cancer. Radiation to the brain can also lower the risk of cancer spreading there. Patients not healthy enough for regular chemo receive lower doses of chemo or palliative supportive care alone. Clinical trials of new treatments may also be another option. Treatments for small cell lung cancer can cause side effects, such as hair loss, poor appetite, nausea, vomiting, diarrhea, and increased chance of infection. Although not every patient gets side effects, your doctor or nurse will teach you how to prevent and manage them. While some treatments might make you feel better, for example by easing pain or making it easier to breathe, other treatments may help you live longer. If you choose to join a clinical trial for small cell lung cancer, know that you will receive the best standard treatment available for your condition. You may also get access to a new treatment that is not available outside of the clinical trial. You might also benefit from the extra care and attention provided by the clinical trial staff. And you will help contribute towards advancing lung cancer treatment for everyone.
Conclusion. Administration of the study drug commenced after randomization of 1 day, once the patient was confirmed to eligible and participate. The study drug was discontinued if there was confirmed disease progression, initiation of alternative anti-cancer therapy, unacceptable toxic effects, or withdrawal of conscience. Patients could receive the study drug until disease progression unless they had rapid tumor progression or symptomatic progression requiring urgent intervention, and could receive the drug again if disease control had been achieved at the end of 12 months, but the disease had progressed during follow-up.
Certainly now that the FDA has approved Durvalumab as consolidation therapy for stage 3 disease after concurrent chemotherapy and radiation, we now finally have consolidation therapy that really does make a difference for our patients with non-small cell lung cancer after concurrent chemotherapy and radiation. This was based on the Pacific data that was recently presented, showing a significant control of disease and progression-free survival advantage to receiving Durvalumab over placebo after having stable or responding disease to the standard chemotherapy and radiation. I think very importantly, they did not see a significant increase in toxicity. Specifically, we're always concerned about pneumonitis in this setting, but it did not seem that Durvalumab added to that toxicity. Certainly we want to see the overall survival data, and hopefully that will be coming as well, but now we have a standard of care. If you have a patient with unresectable stage 3 disease and you plan to give concurrent chemotherapy and radiation, starting Durvalumab after the concurrent therapy is completed does improve progression-free survival.